Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of a patient's left ear. I previously uploaded their right ear procedure earlier on in the week, and that was video number 1553. And I said I would upload their left video separately because both procedures took quite a while. So this patient did have their wax removed elsewhere, but they had a sort of residual skin that's become quite macerated and soft because the patient's been using a lot of drops. So what we're going to do now is just perform a skin peel, and you can see the fresher skin underlying this dead keratin that I'm peeling away. So what is the skin and where does it come from? Now, the ear canal and the outermost layer of the eardrum is lined with the epidermis skin made up of epithelial skin cells. And the skin originates from the center of the eardrum. That's the progenitor site. That's where all these skin cells are formed. And then the skin cells naturally migrate off the eardrum radially. And what I mean by radially, and I've given this analogy a few times, imagine you've got a little puddle or a pond and you drop a pebble in the middle and you get those ripple effects. Now imagine that those ripples of water being skin cells, the epithelial skin cells that are formed and developed at the center of the eardrum. They migrate radially from the center of the eardrum to the outer rim, and then they slowly travel between 1.5 and 3 millimeters a month towards the entrance of the ear canal. And this epithelial skin forms the outer layer of the skin. With regards to the inner 2/3 of the ear canal, the osseous portion, the bony portion, you only have this epidermis layer of skin lining the ear canal, and directly underneath you have the bone. And so the skin that lines the inner 2/3 of the ear canal is probably less than 0.1 millimeters in thickness. However, on the outer third of the ear canal, the cartilaginous portion, the skin has 3 layers. Not only do you have this epithelial skin cells forming the epidermis layer, but you have the dermis layer underneath, and the dermis layer contains all the blood vessels, the nerves, and also the hair follicles. So in the outer third, most people have hairs protruding from the surface of the ear canal, and then underneath the dermis layer, you've got the subcutaneous layer or the subdermis layer, and that's made up of adipose tissue, so fatty tissue. So the skin that lines the outer third of the ear canal is a lot thicker. It's about 1 millimeters in thickness. And this epithelial skin that we're peeling away here, it's actually dead skin. We call it, so the epidermis layer of skin actually has its own 5 layers. The innermost layer of the epidermis skin is called a stratum basal, and that's where the skin cells are formed. So you have parent skin cells, and they undergo a process called mitosis, so it's cell replication, and the daughter cells formed by the parent cells are pushed up into the next layer of the epidermis, and that's called the stratum spinosum. And in that layer, all these epithelial skin cells, they are closely packed, and it gives the epidermis layer its kind of strength and rigidity. And then these cells are then pushed up to the next layer called the stratum granulosum layer. And in this layer of the epidermis, you have granules of natural moisturizing factors. So natural moisturizing factors, help the next layer of skin, which I'll describe in a moment, to absorb just enough moisture in the atmosphere to keep the skin moisturized and lubricated. Now, there is another layer called the stratum lucidum, which is not found in the ear. It's primarily found in parts of your body where the skin is more exposed against friction or pressure, such as your fingertips or the soles of your feet. And in that layer, these granules that are formed, they burst, and that's it's under electron microscope, and that stratum granulosum layer, you can actually see these granules, but in the stratum lucidum, you can't see them because these granules burst. So it's a lucid appearance. It's kind of translucent. But in the ear, you don't have that. And then the most exposed layer of the epidermis skin is called the stratum corneum. And that itself can have up to 20 or 30 layers. But in that layer, the skin cell is actually dead. There's no intracellular fluid, there's no organelles, there's no nucleus. And in essence, the stratum corneum, the skin cells are flat. So they're what we call squamous. You have, as I said, up to 10 to 20 layers of the stratum corneum. So it's stratified, so there's layers of that skin. And it's full of keratin. So keratin is a protein that's hydrophobic. So the stratum corneum is a strange mix. You've got keratin, which is hydrophobic, but you've got these natural moisturizing factors that I described earlier, and they're hydrophilic. So it's kind of a balancing act, because we want some moisture being absorbed into the stratum corneum to keep the skin moisturized, but not too much. Otherwise, the skin will overhydrate, it will absorb too much moisture, and it will overswell and burst at the membranes, and it will macerate the epidermis layer of skin and expose the other underlying layers that I've just described to water and therefore infection. So the skin cells, they undergo a process called cornification. So at the stratum basal level, so the deepest layer of the epidermis skin, the skin cells are called keratinocytes. And as they reach the stratum corneum, the most superficial layer of the epidermis, we call them corneocytes. And so it undergoes this process, and we call that cornification. And it's a constant turnover of keratinocytes, which are then reproduce themselves, and the daughter cell is pushed upwards, up through the layers, until the corneocytes eventually die. And when they die at the stratum corneum level, we call them corneocytes, hence the name stratum corneum. And essentially, this patient's epidermis layer of skin, it's failed to migrate, it's died, and it's shed, and there's multiple layers like an onion, and they're sitting on top of each other. And even at this stage, the patient's hearing significantly better. There is going to be some residual skin, the thinnermost layer of skin, that attempted to peel away, but then the patient experienced the caloric effect. Now, sometimes when you perform microsuction, microsuction reduces the ear temperature, and the organ of balance. So in the inner ear, we've got the cochlea, the organ of hearing, and we've got the organ of balance. We call that the vestibular system. And the vestibular system consists of 3 semicircular canals at different orientations. You've got one semicircular canal which travels upwards, so we call that the superior canal. You've got one going backwards, the posterior canal at an angle, and you've got one facing towards the entrance of the ear canal. You can't visualize this when you examine the ear canal, because it's behind the eardrum, past the middle ear and the inner ear. We call that the horizontal or lateral semicircular canal. And so the organ of balance and organ of hearing are connected, so we call that a labyrinth. And the organ of balance is affected by pressure and temperature. So when you perform microsuction, it reduces the temperature, and by reducing the temperature of the ear, you inhibit the function of the organ of balance. So when you're sat still, your brain should receive equal messages from the organ of balance in your right ear and your left ear. But when you perform microsuction in this patient's left ear, as we are here, this inhibits the function of this organ of hearing. So the brain is receiving less signals and messages from this ear in comparison to the right ear. So your brain is tricked and fooled into believing you're moving. And then you can experience vertigo, because your eyes then try to correct your brain. It's kind of trying to tell your brain, ignore your ears. It's trust the eyes instead. And some patients can get nystagmus. You can actually see the eyes rotating or moving side to side. And so this patient developed some caloric effect. So they got a bit dizzy. It was nothing. I've had patients faint before because of the caloric effect, but they may have also experienced a vasovagal or auditory syncope symptoms when you stimulate the Arnold's nerve. So the Arnold's nerve is a branch of the vagus nerve which runs in the case of this patient's ear, it'll be the southeast portion of the eardrum and the southeast region of the ear canal. And sometimes when you stimulate that, you stimulate the vagus nerve, which causes a reduction in your heart rate. It also causes your blood vessels to dilate, and combined, having reduced heart rate and dilation of your blood vessels mean there's less blood being transported to your brain. So some patients become, they can literally faint and pass out on you. And it's short lasting until it's just for a few minutes, and they should recover. Similarly with the caloric effect, you come out of the ear and you're just waiting for the ear temperature to resolve itself and your eyes to correct your brain, and the caloric effect can be soon resolved. But they did get a bit dizzy, so we just left that thinnest layer on the eardrum. It wasn't going to affect them massively. So we're just peeling some skin here from the posterior superior aspect of the ear canal. So we're slowly approaching the eardrum. So here, because we're working at the roof of the ear canal, I got off my ENT chair and I was almost on my knees looking up into the patient's ear to gain access. The patient had a bit of a stiff neck, so they weren't able to tilt their head. Sometimes you can ask the patient slightly. So in the case of the left ear, I would ask the patient to tilt their head so the right ear is going towards their right shoulder. And that elevates their left ear, so I can view the superior aspect a bit better. But the patient wasn't able to do that because I had a bit of a stiff neck. So I just crouched down, looked upwards. So you can see the difference here already. You can see all that, well, the majority of the skin, that dead skin that failed to migrate, has been removed. I'm just mopping up a bit at the entrance. I'm going to try and remove a bit more of the eardrum. I think they experience the caloric effect a bit later. And so this is a chronic problem for the patient. It is an elderly patient, they're in their 90s, and as we get older, the migration of skin, it slows down because there's less blood flow to the ear. Also, there's less, the ear becomes a bit drier because you have less sebum production and less serum production, which is an oily sweat, and these help to lubricate the ear canal, which can then facilitate the migration of skin. If you've got really dry skin, the epidermis layer of skin is going to find it difficult to migrate because of the friction, and it will slow down. And as it slows down, you get a natural buildup of dead skin. So we're right on the eardrum here, just anterior to the hammer bone, just the umbilical there, which is the center part of the eardrum, just to the right of the suction probe. You can see this skin is coming away, and you can see the eardrum is a bit more blue in that region, but I don't think I'm going to manage to remove all of it, but it's obviously in comparison to before, it's significantly better. I'm going to have one more go, and I think this is where the patient got a bit dizzy in a moment. And it is super, super thin, this layer of skin. And I'm just trying to get a hold of the skin so I can start peeling it, but I did get a hold of it there, but the skin just teared away. I think this is where the patient got a bit dizzy, so we left it. So that you can see the whole eardrum. Yeah, you can see just to the between about 1 o'clock and 7 o'clock, there's the thinnest sheet of skin, but it wasn't going to come away. And as I said, the patient did get a bit dizzy, so we just left it. And the eardrum just flexed there slightly, so we're going to be careful. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.